B chest session. I'll hand over the screen to Dr. Saneej, who will introduce our esteemed external examiner for today and conduct the session.
Yeah, thank you, Sabahat. And I welcome Dr. Harish Narayan to this team meeting. And I am very thankful to him for accepting our invitation. So, hello, Harish.
Hi, Saneej. Thanks for that. Hi, everyone.
Yeah, I'll just introduce Harish to you. He is an Australian now. He is working in Australia, in Melbourne, under Western Health, so which has a large teaching tertiary care health service with 3 hospitals, one in Footscray, one in Sunshine, and one at Williamstown. And he basically did his basic MBBS from Kerala, India. That is from Kozhikode Medical College. And
we were
thereafter
back, me and Saneej.
Yeah, we were back. And Afsar too. Afsar also did one. Yeah, thank you for that. And he did his specialist training, MD radiology from Trivandrum Medical College. That's also in Kerala. That was, I think, in 2008. And he, after that, he did his FRCR in 2009, very long back. And he was working in Melbourne from, I think, from 2010 to 2013 in Capital Radiology, Melbourne. And after that, he did his thoracic radiology fellowship from Monash Health in 2014. And thereafter, he's working from the current job from in that Western Health. So I warmly welcome him. He has so many publications to his credit, and he's a good thoracic radiologist, and he's a good teacher also. He is currently in the examination panel of FRCR, and we are very lucky to have him as an examiner here. So I think the first candidate is Avni. So we'll keep the timer. And Harish, you can share the screen if possible. Avni, can you hear me?
Yes, yes. I hope I'm also audible.
Yeah.
Yep, loud and clear. Thanks, Saneej. Hello, everyone. Thanks for joining from different parts of the world. And let's hope that we can make your couple of hours worthwhile. As Saneej said, I mainly examine for FRCR, and I also teach FRCR candidates. I set my FRCR a long time back, and I realized most of you are actually preparing for FRCR. I guess finally radiology is radiology, so finally we all learn the same thing. So hopefully it'll be useful for FRCR as well. Anyway, I'm good to start. Shall I share my screen?
Sure, sir.
Visible?
Yes. So do I start?
Is it
the timer
nice
is started,
and big and everything, zoomed in?
Yeah,
not too small.
It's perfect.
Okay,
it's perfect.
excellent.
No,
all right,
perfect.
so this is a 63-year-old female presenting with right-sided chest pain for 1 week.
Okay. In this frontal chest radiograph, I can see that there is an opacity that is projected over the mid and the lower zone of the right hemithorax. I'm not able to demarcate the cardiomediastinal contour or the right hemidiaphragm in this area. The costophrenic angle is also not well visualized. I'm looking at the rest of the lungs. I am not able to appreciate any obvious osseous lesions, though I am not able to make out the right breast shadow on the right side. So yeah, the right breast shadow. So and I'm also seeing some surgical clips in the right axillary region, favoring the fact that this patient has had a prior mastectomy, possibly a malignancy history. So in this patient, if this patient is having raised inflammatory markers, in this current presentation, I would be thinking of an infective consolidation.
No infective signs or symptoms.
Okay, then with the background of mastectomy, and I would just like to relook my images again. I have a feeling that there are some nodular shadows that I'm able to see in the retrocardiac region also, which is in the left lung possibly. So with a background history of malignancy, cea breast, I would be thinking of pleural metastasis and pulmonary metastasis. And this patient would need to be referred to the oncology team for reevaluation.
Next case, it's a 60-year-old man with chronic shortness of breath.
Okay, in this frontal radiograph of the chest, I am seeing that there is diffuse reticulonodular shadows that I can see involving both the lung fields with no particular zonal predominance. However, I am not able to see the diaphragmatic contour well. There's some kind of dirty shadowing seen in the costophrenic angles also. Considering that this patient has had, I'm suspicious of there being some calcified plaques in the costophrenic, in the diaphragmatic aspect. And considering that this patient has been having long-standing symptoms, I would be concerned of an underlying interstitial lung disease. And if this patient has any exposure of any asbestos, I would like to consider the possibility of asbestos-related lung disease also, but I'm not too sure about the calcified plaques. However, this patient, I would like to compare with the previous images to see if this was there earlier or if this is a progression. And this patient would need an HRCT thorax and a chest physician referral. Okay,
he didn't have any old X-rays. Yeah. Shall I scroll for you?
Yes, please.
So
please,
here
Doctor.
are the lung window sections from his HRCT.
Okay, this is
Start
showing
from the top again.
scattered. Okay. I'm looking at the serial axial images of the thorax, in which I can see that there are scattered fluffy shadows that are seen in the central and peripheral distribution of both the lungs. There is no particular zonal dominance I'm seeing. There's some amount of fibrosis in the lower aspects with there's some amount of fibrosis, and I think there's some kind of nodular changes also I can see. This considering that this patient is having a long-standing history, the possibility of an infectious etiology is less likely. I am not able to appreciate any discrete nodular peribronchovascular distribution in this case. I would like to know if this patient has any history of recurrent sinusitis, because some of the opacities, no such history. Okay, so I would still like to proceed, considering that this patient has an underlying interstitial lung disease with a secondary infection.
Would you like to look at anything else?
Can I see the mediastinal window? Okay, there's some calcified nodes that I can see. I'm sorry, I should have asked for it earlier. There are some calcified mediastinal nodes that I can see in this. So this could be a patient, if this patient has a raised ACE levels, this could be a case of sarcoidosis also. And I would like to reevaluate with the history and the lab parameters.
How would you confirm your diagnosis?
I would check for the AC levels in this patient. I would actually presume that this patient would be having mediastinal hilar nodes, though I'm not seeing them.
Okay, next case. This is a 60-year-old with acute chest pain, which woke her up from sleep.
Okay. In this elderly female patient, the frontal chest radiograph, who was presented with acute chest pain, I'm looking at the lungs, and on the first look, I'm not able to appreciate any obvious pathology or abnormality in the lung fields. I'm looking at the costophrenic angles. They look normal. I'm looking at the apices, which look normal to me. I'm looking at the retrocardiac region. Again, I do not see any abnormality. The cardiomediastinal contour and the hilar look normal. I'm looking at the osseous structures, and I'm not really able to appreciate any abnormality in the osseous structures either. I'm looking at the shoulder joints. They look normal to me. There's no resorption. In this patient, considering that I'm not able to find any abnormality within the lung fields or the costophrenic angles or within the airways, I would like to consider the possibility that there might be some underlying vascular pathology which might need a contrast CT, possibly an angiogram, to assess the vascular structures better. I'm not able to proceed further.
So he had a CTA. This is the non-contrast CT from his CT aortogram.
Okay, I could see that there was some dense structure that was seen within the esophagus. So this is a foreign body in the esophagus, and this could be correlated with a history of swallowing in this patient who must be a fishbone, looks like a fishbone. So this could be correlated, and this patient would require an urgent referral to the for an endoscopic removal of the foreign body.
Do you like to review the X-ray?
Yes, I'm so sorry. There is actually a linear structure that we can see, which is projected posterior to the trachea. And this correlates with the history of this patient.
This is someone with shortness of breath for the last 2 weeks.
Okay.
39 years.
Okay. In this frontal radiograph of the chest, I am looking for any obvious opacities in the lung fields. I am not able to appreciate any discrete consolidative segments. No areas of collapse are seen. The costophrenic angles are blunted, but I do not see any evidence of pleural fluid. I am looking at the cardiomediastinal contours, which are looking normal to me. The hylae also appear normal. There is mild prominence of the bronchovascular markings on either side. I'm not too sure if it is the windowing, which is it. There's some mild prominence of the bronchovascular markings on either side. Further to this, I'm looking at the apices. I don't see any abnormality in the apices. There is no retrocardiac abnormality I'm able to see. The diaphragmatic contour is not well visualized on either side, but predominantly on the right. So I'm not too sure. I'm looking at below the diaphragm region, and I am not finding any abnormality in below the diaphragm also. I am looking at the bones, and I'm not finding any abnormalities in the osseous structures. So in this patient, where I'm finding this increased bronchovascular markings bilaterally, and the hylae are looking relatively normal, I'm thinking that there is possibly some reticular shadows that is there involving all the zones of the lungs. And this is a long-standing history, so I would like to consider a possibility. 2 weeks, yes. So this is a 2 weeks history, so I would like to consider that. Did you just point something for me? Sorry.
No. That's
okay.
Somebody else. I don't know.
Okay. Okay. So considering that this is a 2 week history and there's increased reticular shadowing, I'm thinking the possibility that this patient might be having some kind of a viral pneumonitis, and this patient, if this patient has raised inflammatory markers, I would consider an infective spectrum like a viral pneumonitis. I'm sorry, I can't proceed.
The patient was treated as for infection, but didn't improve over the next few weeks, so went on to have a CT. And I'll scroll through the.
Okay, on the CT, the serial axial thorax shows in the lung window shows that there is subtle centrilobular ground glassing densities that is seen throughout the lung with no particular zonal predilection. If this patient is known to be having any allergy or any allergen exposure, I would be thinking of, and with a history of 2 week history, I would be thinking in the lines of a subacute hypersensitivity pneumonitis. If this patient has any malignancy history, then this could also represent endobronchial spread of malignancy. However, my diagnosis would primarily be subacute hypersensitivity pneumonitis. If this patient would require an urgent separation from the allergen, removal of the allergen exposure, and this patient would need a chest physician referral.
What kind of allergens
Harish,
are you thinking of?
Yeah,
time up.
Time is up. Yeah.
Okay.
Yeah. Something like hay or birds.
Birds. Yeah, sure. We got 5 minutes to discuss. Yeah, Sanij.
Yeah.
Okay.
Yeah.
Avni, that's you're sitting FRCR, yeah? Is that right?
Yes, very close.
Yeah. So just general feedback. Your voice is crisp and clear, very easy to follow. That goes a big way. You don't want to be hard to understand. And you are saying all the right things, which you should say in every case, such as asking for rolled X-rays. That one, for example, just ask it in each and every case. It should be part of your spiel, because they may not have an old X-ray in many cases, but if they do have it, you don't want to miss the opportunity to see it.
Sure.
Just the cases, yeah, this one's really good. I wouldn't really, so the X-ray is hard. It's just, as you said, it's just some increased reticular nodular shadowing, or even just coarsening of bronchovascular markings. It's the CT which would really gives you the diagnosis. I wouldn't really consider METs when it's typically centrilobular like this. The other condition which you would think of would be RBALD if this is a smoker,
Yes.
but it looks fairly classic for subacute HP. The foreign body case was good. It's again tough on the X-ray, and I know it may not project that well either. But on the CT, I would have expected you to mention some pertinent negatives. Yeah, pneumomediastinal, no mediastinal abscess, etc., etc. The case before, I would like to bring that
I was kind of lost in that.
No, overall, I would definitely pass you if I only had 15 minutes to assess you. Overall, it is definitely a pass. So the right is this. This one on the CT, it's a fairly good case. You did mention sarcoid, which is what this was. It's a good case because it's got a few named signs which are quite classic for sarcoid, but not seen in every case. So you did mention there may be plaques on the X-ray, and even on the CT, it looks like some of these look more plaque-like rather than pleural nodules. So that's kind of well described in sarcoid. It's called pseudoplaque formation. So when the perilymphatic nodules along the pleura, they coalesce into bigger areas, it start to resemble plaques. So that's well described. And these fluffy nodules, as you described in the upper zones, this looks fairly convincing for what's described as a galaxy sign. So if I zoom in and we start to look at each of these, you could call this one a galaxy. So galaxy is essentially, again, multiple peribronchovascular nodules just coalescing together and forming a larger ill-defined nodule. But along the periphery, you'll have these more discrete nodules. So it looks like a galaxy with many stars around.
When you describe it, looks classical.
Yeah. And like you said, it's not your most classic perilymphatic nodules, but there are many nodules along the fissures, right? There is that beaded septum appearance as well.
Yes.
And with the calcified nodes, I think it's fairly good for sarcoid.
I didn't even ask.
With ACE inhibitor, it's a good test. Everyone gets a ACE level, not ACE inhibitor, but ACE levels. But it's not specific by any means, or even that sensitive. So you shouldn't hang your diagnosis on that. It's just something which complements everything else. If somebody says the ACE levels are normal, it doesn't mean that it's not sarcoid. Most of the times, you diagnose it based, if radiology is typical, then that's enough. Otherwise, if you need a definitive diagnosis, it's almost always a EBUS sampling of the nodes. If there are no nodes, then you may need to do a transbronchial lung biopsy, but most of the times it's EBUS sampling of the nodes, unless they have peripheral nodes or skin lesions or something like that.
Okay.
All right. Breast mets was good. That was just more of a warm-up case. If you had seen the mastectomy and the clips straight away, I would advise to speed things up, because things which you see, you also want to go through as many cases as possible, right? So once you know, just be a bit more quick about it. Yes. But if you were looking at the lungs and pleura first and only then saw the breast changes, then it's fine. But if you had seen it, my professor would not let anybody proceed unless they start off by saying there is mastectomy and axillary clips. So he would say that first, because that look for that first when you see effusion in a female, in a young female. Anyway,
Got it,
overall,
yes.
good. I would definitely count that as a pass.
Thank you. Thank you so much.
Okay, thank you, Harish.
Great.
The
Good
next
to
is
proceed.
Dr. Abhijit.
Hi, Vijay. You
Hello,
ready?
sir. Yes, sir.
Okay.
Okay, I am keeping the timer.
Okay, here is a 65-year-old with acute shortness of breath.
This is the frontal chest radiograph of a 65-year-old patient with shortness of breath. I can see there's a diffuse reticulonodular shadowing seen involving bilateral lung parenchyma without any zonal predilection. I can see there's opacity seen in right lower lung zone with well-defined margins. I cannot see any calcification seen through the opacity. Bilateral costophrenic angle is somehow blunted, but no obvious pleural effusion seen. Cardiac silhouette is unremarkable. Visualized bone appears normal. No evidence of pneumothorax or pneumomediastinum seen. So, in summary, there is a bilateral sided reticular nodular opacity with right lower zone opacity. So, my differential include sarcoidosis or any underlying interstitial lung disease, likely scleroderma or connective tissue disorder with underlying opacity. So I'll I refer the patient to the referring clinician and advise HRCT thorax for further evaluation.
Okay, the patient had a repeat X-ray in 1 week's time.
Okay. Now I can see there is a resolution of the opacity in the right lower lung zone. So it must be the inflammatory process. After the course of antibiotic, it has resolved.
Okay. The patient represented in 2 more weeks with acute shortness of breath.
The same patient? Huh?
Yeah.
Okay. I can see the opacity in the right lower lung zone with reticulonodular opacity involving bilateral lung parenchyma with prominence of bilateral hyla. So the underlying pathology can be some inflammatory process or hypersensitivity pneumonitis or some interstitial lung disease, the possible cause also, but I'm not sure. So I advise HRCT thorax for further evaluation.
Okay. Here is an X-ray from 1 week later.
Okay. There's a resolution of the opacity with.
And here is an X-ray from 2 more weeks later.
Okay. Okay. So basically, there is opacity in the right lower lung zone with reticulonodular shadowing. So I'll correlate with any underlying drug history if the patient is taking. With central line is seen in situ in the patient. So there must be underlying drug or acute illness in the patient. So I'll correlate with the history of the underlying drug. So the possibility is having, if the patient is immunocompromised, then the
Not
PCP
immunocompromised.
infection, or
Immunocompetent.
can it be cystic fibrosis with underlying consolidation? So I correlate with the history and and refer the patient to the chest physician for further evaluation and management.
Okay. This is a 79-year-old with cough for a few weeks.
Okay, the frontal chest radiograph of a 79-year-old patient with cough for few weeks history. I can see there's a veil-like opacity seen involving the left lung parenchyma with loss of volume of the left lung with tenting of left hemidiaphragm seen. I can also see the left sided left facial sign noted. Left hyla is somewhat bulky. On the right side, I can see the nodular opacity in the right middle and lower lung zone. Rest of the lung appears normal. Visualized underlying bones appears normal. No evidence of any lytic or sclerotic lesion noted. So in summary, in the old patient with left upper lobe collapse with left hyla bulky, I am suspecting underlying neoplastic process. So I'll convey my findings to the referring clinician and advise CT thorax, CT thorax for further evaluation and management, and with CT staging if the underlying malignancy is confirmed, and with histopathological diagnosis.
This is an 18-year-old with cough for 4 weeks.
This is the frontal chest radiograph of a patient with cough for 4 weeks. I can see this bulky right hyla with prominent right paratracheal stripe. Visualized bilateral lung parenchyma appears unremarkable. I can see there is a mild blunting of left costophrenic angle. Right costophrenic angle appears normal. Visualized cardiac silhouette appears unremarkable. Central airway appears normal. Visualized bone appears unremarkable. So, in summary, there is right paratracheal stripe prominence with bulky right hyla. I am suspecting the sarcoidosis in the patient, or differential can be lymphoma or tuberculosis. I'll convey my findings to the referring clinician and refer the patient to the chest clinic and advise HRCT or CCT thorax for further evaluation and management.
Okay. Here's the CT. I'll just scroll through the lung windows first.
Okay. I've been provided with axial sections of HRCT thorax. I can see these centrilobular nodules with tree invert configuration involving apicoposterior and the segment of right upper lobe with central cavity tree lesion in the apicoposterior segment of right upper lobe, and also involving the right middle lobe. In the mediastinal window, I can see there is mediastinal lymphadenopathy predominantly in right paratracheal and postcranial region and right hilar region. So in summary, I'm suspecting underlying inflammatory or infective process, most likely COX in this patient, and differential can it be sarcoidosis, but that is less likely. So I'll convey my findings to the referring clinician and refer the patient to the chest clinic, and this patient need isolation and start, and I'll advise starting antimicrobial therapy for the patient.
Next up is a 40-year-old with non-specific aches and pains.
This is a patient with a 40-year-old patient frontal chest radiograph. I can see there is mildly hyperinflated lung parenchyma on the bilateral side with thinning of ribs predominantly on the right side. Visualized lung parenchyma appears unremarkable except for the mild bronchovascular markings prominence on the bilateral side. Cardiac silhouette is mildly tubular, however, appears normal. No bilateral costophrenic angle appears unremarkable. So, visualized bone appears normal. Right apical opacity is noted with mild apical pleural thickening is also seen. So in this patient with prominence with hyperinflated lung with tubular heart and thinning of the right sided ribs with apical pleural thickening, I am suspecting underlying COPD in the lung parenchyma, bilateral lung parenchyma, with thinning of the ribs can be due to the underlying can it be because of neurofibromatosis or apical pleural thickening or apical pleural opacity is noted. So I like to confirm it on the HRCT thorax to rule out any underlying malignant process involving the right epicyst. So I'll convey my findings to the referring clinician and refer the patient to the chest clinic for further evaluation.
Patient also had an abdo X-ray at the same time.
Okay. This is the frontal radiograph of the abdomen. I can see there is medullary calcification involving the bilateral kidney, and I can see there is peritoneal dialysis catheter seen. So I am suspecting some underlying bilateral renal pathology going on. Rest of the visualized mm, X-ray appears unremarkable. No prominence of bowel gas seen. Rest of the visualized bones appears normal. So this is the bilateral medullary calcification. The differential include hyperparathyroidism or medullary sponge kidney or renal tubular acidosis. But because of the peritoneal dialysis catheter, my prime diagnosis would be hyperparathyroidism with underlying kidney bilateral renal pathology. So I'll correlate with the previous radiograph and convey my findings to the referring clinician. This is the
skull X-ray. Confirm your
skull skull radiograph. I can see this cotton wool appearance involving the calvarial bone with mild punctate opacity seen. No evidence
Harish,
of
time up.
Okay.
Okay.
All right, Abhijit. First step, as you again very clear and very easy to understand. No issues there. One thing in general I would advise you is you don't ask for old imaging enough.
Okay.
As I said, it just takes 10 seconds to say. You don't want to lose that opportunity. So unless it's somebody who is presenting acutely and in shock, where you're not really thinking of anything pre-existing, virtually every case can get some help from old imaging. So always ask for old X-rays.
Okay. Okay.
The last one, it was hyperparathyroidism. It's tough, but if you had seen that medullary nephrocalcinosis on the chest X-ray, it's visible. In hindsight, you can see it. Again, I don't know how well it's projecting. It's here. And there is this rib lesion, which is a brown tumor. There are some other small bone lesions, which is too hard to pick. It was seen better on CT. There are small lytic lesions here, but even just rib lesion and these thin gracile ribs plus nephrocalcinosis still should guide you towards that, some kind of metabolic bone disease. The other thing is on the abdo X-ray, you said the bones are normal. They really are not. There are multiple lytic lesions here all over the pelvis. There is more in the ischium here. But eventually you got there. I would probably treat that as a borderline to fail. And the case where the opacity in the right lower zone was coming and going, even infective lesions, they resolve, but they shouldn't resolve in a few days or a week. Even if it resolves, it shouldn't keep coming back week in. 1 week it's there, next week it's not there, the next week it's again there. What kind of thing causes that kind of rapid appearance and resolution and reappearance?
Some sort of like pseudo tumor picture, or
what kind of sort of pseudo tumor? What are you thinking?
Means fluid and the faces, or
exactly. What do you call it? Phantom tumor?
Phantom tumor.
So there is no way you can call this a phantom tumor on the first X-ray, but seeing its behavior, there is virtually nothing else which can appear and disappear in a matter of few days. And then when you look at it, though it may not be the most classic, you could call everything else in the background cardiac failure. And also interestingly, the X-rays where it's relatively resolved, those cardiac failure type changes are also less. So it's just coming and going.
Yes.
And the heart's smaller as well.
Yes.
What else? Left upper lobe collapse was good. TB was good. I wouldn't really say sarcoid once you start to see train bud nodules and cavitating lesions. And I would recommend to recommend calling it tuberculosis rather than COX. It can. It depends on how commonly that terminology is used, and you don't know what your examiner is used to.
Okay.
Don't want to confuse. And well done for saying isolate the patient.
Okay. Okay, sir.
All right.
Okay. Thank you, sir.
Have we more?
Okay, thank
No
you, Harish. So we'll call Dr. Abhishek now. Dr. Abhishek.
Yeah, Dr. Saneej. Yeah.
Okay.
Abhishek, ready?
Hi, Dr. Narayan. Yeah.
Okay. One sec. Okay, so this is a 69-year-old female with cough for 1 week. Cough and low-grade shortness of breath.
Okay, so elderly. Okay, so elderly patient with acute short history. This is a frontal chest radiograph, and I can see ground glass or airspace opacities in bilateral upper zones, and the bones, the costophrenic angles, the breast shadows, the cardiac silhouette, they all appear normal. So in acute history of airspace opacities or ground glass opacities, I'll be thinking of infectious or inflammatory etiology. In COVID pandemic, it can be COVID infection if this is a recently done X-ray.
Okay. So patient was treated for infection, and this is after 4 weeks.
After 4 weeks, so the opacities are persisting. So I have to think of the causes of multiple chronic opacities. These can be chronic eosinophilic pneumonia. It can be lymphoma. It can be bronchoalveolar carcinoma, chronic hypersensitivity pneumonitis, chronic eosinophilic pneumonitis, and I'll convey the findings to the chest physician and arrange a CT chest for further evaluation and characterization of the opacities.
Check. I'll give you the CT in a sec. Okay, I'll just scroll through the CT. I need to start speaking, Abhishek.
So these opacities, these are airspace opacities with surrounding ground glass halo that indicates hemorrhage, surrounding hemorrhage, and there is no other focal lesion in the visualized lungs. So I'll be thinking of in this age, I'll be thinking of hemorrhagic metastasis, bronchoalveolar carcinoma, and vaginals I would be expecting to be cavitating, and fungal infection could also be persisting for 4 weeks, and I would like to elucidate from the clinic, discuss it with the clinician, and if there is history of fever, febrile or raised markers indicating infection. Otherwise, I'll be thinking on the line of hemorrhagic metastasis, lymphoma or bronchoalveolar carcinoma. And I would convey the findings to the chest physician and arrange a bronchoscopic or CT guided biopsy after evaluating the feasibility.
Yeah. Next case is a 32-year-old with low-grade chest pain for 4 months.
So the most prominent abnormality is an opacity in the left hemithorax. It is having a broad base towards the mediastinum. I can see the hilar markings through the lesion, and but the angles with the mediastinum, they appear to be acute. The cardiac silhouette is partly obscured underlying the lesion, so this can be an anterior mediastinal lesion or It can also be a lung lesion. And I would discuss the findings with the referring clinician, arrange a lateral chest X-ray before proceeding to the CT. So the differentials are an anterior mediastinal lesion or a chest lesion. Yes, on the lateral chest X-ray, the lesion is conforming to the anterior mediastinum. There is no calcification, there is no fat density. So I rule out a germinoma. Lymphoma, it cannot be because it is just a solitary lesion. It might be a thymic lesion, but I'm thinking of. I would suggest a CT chest, contrast enhanced CT chest for further evaluation, characterization and confirmation of findings.
I'll just scroll through the CT.
So this is a thymoma, what it looks like to be. It can also be a germ cell tumor, like seminoma or something like seminoma that can look like this. They're definitely not a lymphoma or a teratoma. The thymus, I can see part of the thymus lying separate from the lesion also. So.
Next case is a 40-year-old. Oops. Let me see if there was an X-ray. Okay. It's largely pointless to show the X-ray now, isn't it? Anyway, here it is. 40-year-old acute shortness of breath.
Okay, so I'm able to see ground glass haziness diffusely in bilateral lower, mid and lower zones. Acute shortness of breath. I can be thinking of ARDS, or it is too diffuse to be pulmonary embolism, and pulmonary edema. But there is no pleural effusion and the cardiac size appears normal. There are no curly B lines. There are no vascular. So diffuse opacities. Yeah, pulmonary edema can be pulmonary hemorrhage, can be ARDS. Since there are, I can see ECG leads, the patient is sick, maybe in ICU, pointing more towards ARDS, no pleural effusion also. Can we discuss the findings with chest physician, ask for history, correlate with the history, and then arrange a CT for further evaluation.
The patient was still worsening, so
cardiac.
then don't have a CT.
So there is diffuse ground glass opacity in both lungs. In fact, involving all of the lungs, and there is a bit of a craniocaudal gradient. There is no pleural effusion, and the mediastinal structures, the bones, they grossly appear to be normal. There is a mucus plug in the trachea. So I'm thinking of ARDS. That's my diagnosis.
Can you think of any etiology for
cannot be so diffuse.
ARDS?
In a young patient, it can be something like near drowning, or it can be inhalation of some toxic gas like carbon monoxide. Patient caught up in some garage or some fire or something. Young female, maybe she delivered and went into some, she was peripartum or something. She could have gone into some shock. I'm suspecting a bit of pneumothorax on the right side.
This is a 60-year-old with low-grade shortness of breath.
Okay, so the abnormality that's catching my eyes is few small nodules, scattered nodules in bilateral lower lung zones, and a small one in the left perihilar region, and a small opacity in the right peri or infrahilar region. The costophrenic angles, the bones, the cardiac silhouette they appear normal. So few nodular opacities in an elderly male. I'm thinking of metastasis, or this can be fungal infection. There is no lymphadenopathy, so I'm not thinking of sarcoidosis. Silicosis can also present as small nodules, but they'll be more numerous, and there might be some other findings of fibrosis or calcification. So I'll discuss it with the clinician if the patient is having history of any malignancy or weight loss in the recent months. Then I'll be thinking in the line of metastasis, or if the patient's clinical profile and the blood markers go in favor of infection, then I'll be thinking of fungal or viral infection. Discuss the findings and arrange for CT, bronchoalveolar lavage, and correlate with the clinical picture.
Here's the CT. I'll scroll through it.
I could see some nodules in the peribronchovascular distribution and a few small lung cysts. I'm also doubting that these can be AVMs. Those can also present as small nodules. For that, I would like to see on some of these nodules. For that, I would like to see on contrast enhanced CT. Some of these nodules are also in subpleural distribution, and they are showing some cavitation also. And for cavitatory nodules, I'll be thinking of vaginals also, and septic emboli, cavitatory metastasis.
Okay, do you think they are AVMs?
No, I don't think these
okay.
are AVMs.
So what all are your top differentials?
So cavitatory nodules in subpleural and peribronchovascular distribution. Again, cavitatory metastasis, vaginals, fungal infection, like invasive aspergillosis, correlate with history of any malignancy, or immune status of the patient should also be evaluated, because fungal infections are preponderant in immunocompromised patients. There are few lung cysts also.
What do you think of the cysts?
Yeah, that's it. That's all I have to say.
Harish, time is up.
Okay, sure. Okay, Abhishek, good. Your differentials are really good for every case. I'm very impressed by the list of differentials, and that's the right approach to go about it as well. Start broadly, especially if you don't know if they're presented acutely or not. Again, similar to the last candidate, you don't ask for all the X-rays enough, especially cases where you are suspecting even the mediastinal lesion. Yes, you will do a CT and you would want to characterize it on a CT, but you would always look for old imaging. And if you know that it's been there for 4 years, you know that even if it's a thymoma, it's not an invasive or malignant thymoma. It's more of a benign thymoma. So do ask for old imaging. I think that's something you definitely need to improve. This one, I completely agree with your differentials for cavitating nodules. The only thing I would say is that this patient has got these nodular lesions, and then there are cavitating nodules like this one here, but then there are actually thin-walled cysts, and most of those conditions which you described, which produce cavitating nodules, don't usually evolve into cysts, these very thin-walled, completely cystic-looking lesions. So I think we also need to start thinking of
LCH.
So LCH nodules are generally not this big. They start to cavitate before that, and they are often more numerous. And the cysts, some of the cysts are bizarre shaped, but you often see the nodules are often smaller, isn't it? but some of the other cystic lung disease conditions I would definitely consider. So you would think of LIP, but you generally expect more ground glass opacities and some fibrosis with LIP. The other more rarer conditions are amyloidosis and light chain deposition disease. So this was a biopsy-proven amyloidosis. It's you won't be able to give that diagnosis as a single specific diagnosis, but once you start to see such thin wall cysts, I think it's reasonable to expect to start thinking of those cystic lung disease conditions as well. I completely accept your differentials of rheumatoid nodules and etc. And then and Mets, yeah, again, it would be unusual for Mets which are not treated to go so cystic and be so thin walled and smooth. You usually expect some degree of solidity to remain. And then some of the other conditions you mentioned doesn't really fit with the clinical picture. So I think it was very non-acute, low-grade cough. So this was amyloidosis. It's just something. If you will pass if you give a reasonable list of differentials, even if you don't say amyloidosis. But I would expect you to say some cystic lung disease conditions. Thymoma really good, and I like how you said it's definitely anterior, but it could be pulmonary, right? So that inferior margin was quite acute. I would recommend you in that case. The only thing I would feedback is that try not to use terms such as cannot be. So I think you said cannot be lymphoma. I understand what you're saying. It's very unlikely to be lymphoma. That's a much better way to say it. Even if you're essentially saying the same thing, but you know, in an exam situation, you don't want to sound arrogant, or not arrogant, but too confident that you may end up causing harm. You're essentially saying the same thing when you say it's unlikely to be against cannot be, but unlikely to be just sounds nicer. And also when you said this is thymoma, it's good, but most of the anterior mediastinal mass lesions, you can't give 100%. You can't be sure for 100%, right? I agree. It's most likely to be thymoma, and it turned out to be a thymoma. But I would recommend saying most likely to be rather than disease. If there was calcium and fat, and it looked like a teratoma, then you could say this is teratoma. That case also had some calcification, but it still looks like a thymoma. And the one with the CT halo, I'll definitely call it a pass. The X-ray was to just look at your approach. So treat like infection, not resolving CT. These are the other things you'll consider. Good differentials. It was Wegener's. Once you see that CT halo, it's again not specific, but your top two differentials are vasculitis and angioinvasive angioinvasive infections, mainly fungal. But all of the other things you said are also things which can cause a CT halo appearance. But and Wegener's don't always cause cavitation. If there was cavitation, it would have been more of a clincher. That was also a proven case of Wegener's. Oh, and the diffuse changes, yeah, it does look like ARDS, right? Just going through the causes of ARDS, the other thing in a really young patient would be acute severe infection. That patient had a few cysts in their parenchyma. This was somebody with HIV and PJP, but by the time we've done the CT, it is ARDS. And like you said, it's got that nice gradient, the gravity dependent gradient with more denser opacities towards the posterior aspects. But I guess it's probably unreasonable to ask you to say PJP. You know, once you know a case, everything becomes easier in hindsight. There were a few small cysts, but I accept that it was probably unreasonable to expect you to see those tiny cysts in such a diffusely abnormal lung. All right.
But I could have mentioned that in differentials of diffuse opacity.
Yeah, acute severe infection. Any acute severe infection, including COVID, can lead to ARDS, right? That's how the lung just responds to just severe insult. So yeah, if you had asked for history of immune status, I think it would have been, you would have gotten credit for that. Okay, any questions?
Yeah. Okay, Harish. Next is okay. You can ask questions now.
Yeah,
Is there any question?
how did you get to work in Australia after FRCR? That's off the
Yeah,
topic.
I'll tell you after the session. Okay. So
We should have another meeting to discuss that.
We'll discuss that. Okay, so next
You can just ask Sanij. She's doing the same.
Okay, I'll tell you. No worries.
We can chat after the meeting offline.
Okay.
Was it Abhishek?
Thank you.
Yeah.
Yeah. Okay. Yes.
Okay.
Thank you so much.
Yeah. Yes, Abhishek. We'll definitely help you. So next one is myself, Harish. Yeah.
Oh, okay. I have to find some really tough cases now. Clock ticking?
Yeah, I started. Yeah.
Okay. This is someone who is being worked up for pulmonary hypertension because she was chronically short of breath and echo showed signs of pulmonary hypertension.
Okay, so this is the frontal radiograph of the chest of an adult patient worked up for pulmonary hypertension. So I can see some diffuse abnormality in the lungs, predominantly involving the right lower zone. There is some airspace opacities in the right lower zone. And I can also see some opacities in the right upper zone also. Apart from that, the heart looks normal, but the heart shadows are shaggy. They are not well defined, maybe due to some reticular shadows. So I'm looking at the bones. I'm looking at the retrocardiac region, subdiaphragmatic region. I'm not finding anything, and the breast shadows are fine. So in summary, in a patient coming with worked up for pulmonary hypertension with shortness of breath, chronic shortness of breath. So I can see a diffuse reticular shadows and some airspace opacities in the lower zone. So this can be a chronic interstitial lung disease like UIP or any sort of like that. So I would like to see the previous images for comparison to see whether the progression of the disease, and also we'll discuss the case with the referring clinician, and we'll arrange for an HRCT chest. And
okay, so we didn't have any previous imaging. I'll scroll through the CT now. Here are the,
so these are the
soft tissue window settings.
Yeah, these are the soft tissue windows. I can see some mediastinal nodes, and also I can see some collapse of lung on the left side. So I'll compare with the lung window, and I can also see, I'm also looking at the pulmonary vasculature. So here in the lung, I can see train bud appearance randomly scattered, predominantly on the right side, and there are some dense nodules also I can see, and there are some ground glass opacities in the right lower lobe, and there is some hyperinflation on the left upper lobe, and there is some collapse also, subsegmental collapse. I am looking for any cause of the collapse here. So in summary, there are multiple dense nodules with some lymph nodes and some so if this patient has any occupational exposure to silica or something like that, it can be occupational lung disease like silicosis is a possibility considering the nodules. And looking at the pulmonary vasculature in this MIP window, I can see the main pulmonary artery, and I am also looking at the descending pulmonary arteries. There is some narrowing of the pulmonary arteries because of the extrinsic compression, and some soft tissue that is outlining the mediastinal vascular structures. It can be fibrosing mediastinitis also. It's also a possibility. So I'll discuss this in the next respiratory meeting, and we'll arrange for an EBUS guided biopsy of the mediastinal lesions for confirming the same.
Next is a 66-year-old with cough for 2 weeks.
So it's a 66-year-old patient coming with the cough for 2 weeks. The most predominant abnormality I can see in this frontal radiograph of the chest is opacities involving the right mid and lower zones, which are airspace opacities, which I can also see some air bronchograms there, and I can also see some prominence of the hila, predominantly on the right hila. But the left hila is also prominent. The cardiomediastinal contour appear normal. The right upper zone, both lung upper zones appear normal, and also the left lung lower zone and mid zone appear normal. The bones are fine, and so in summary, in a patient with shortness of breath, I can see some bilateral hilar opacities and parenchymal opacities. So I'll compare the previous images to see whether it is an acute finding or a chronic finding. And I'll also...
So this X-ray is from 1 year back.
So in this X-ray in 1 year back, I'm not seeing the pulmonary opacities on the right lower and mid zone, but the hila is also... but hila is prominent on the right side, but I can see some opacities on the left lower zone in this X-ray. So this is a chronic process. It can be related to, I'll also look at the patient's history, like whether this patient is having any occupational exposure, because in the previous radiograph, I think that maybe pleural plaques are seen in the diaphragmatic contour. I'm not pretty sure. I can see a calcified pleural plaque in the diaphragmatic contour on the right side, and those can be I look at patient's history, occupational history, whether there is any asbestos exposure. If so, it can be asbestos related pleural disease and pulmonary disease. So I'll arrange for a HRCT of the chest, and we'll refer this patient to the pulmonologist, and we'll discuss in the next chest meeting. So here I have been provided with the lung window of the CT, where I can see air consolidation with air bronchograms involving the right lower zone with some atoll sign like clearing. It can be organizing pneumonia is a possibility. With if this patient has presented in this COVID endemic era, then it can, I will think the possibility of a COVID-related pneumonia also. And so there are some central clearing with the atoll sign. It's a possibility of organizing pneumonia. So I'll discuss with the referring clinician, and he'll arrange for a steroid dose and repeat the X-ray or repeat the CT after this. And if it is not clearing, then we'll arrange for a guided biopsy. And this halo can also be seen in vasculitis also.
It's a reverse halo, right?
That is a reverse halo.
It's a reverse halo, yeah. Okay, next case, 23-year-old. Don't think you'll need history.
A 23-year-old with the frontal radiograph of the chest, there is a mediastinal mass on the right side with well-defined lateral borders. The medial border is merging with the mediastinum, and I'm looking for any hilum overlay sign. And I'm also looking for the superior border of the lesion, whether it is going above the clavicle. And I'm also looking at any lung lesions and bone lesions. So in summary, in a young patient, I'm seeing a mediastinal lesion. So I look at the previous radiograph to see whether this is a chronic case or a acute case, and also look at the lateral radiograph if available. I'm thinking the possibility of an anterior mediastinal mass here. I'm also looking for any calcification. I'm not seeing any, but I can see some lucency, but that is bronchial shadow. So this can be in a young patient, it can be teratoma, but I'm not seeing any calcification. Lymphoma is also a possibility, but the age group is not fitting. And lymphoma is also a possibility considering the prominence of hila on the left side. So this is the reverse. Okay. So I'll arrange for a CT.
Sure.
Okay.
So patient had a CT and showed an anterior mediastinal mass, had a biopsy, it was a lymphoma, and got treatment for lymphoma. The patient also gives history of recurrent infections since childhood, and now she's again presenting with recurrent episodes of chest infection.
So
And
if
this
there is a
X-ray is after treatment.
yeah, same patient? Yeah, the same patient with the recurrent chest infection, I can see a PIC line inserted from the right side with the tip at the cavo-atrial junction. So the upper zones are predominantly well inflated, but in the lower zones, predominantly on the right side, I can see reticular shadows with linear shadows. It can be due to bronchiectasis. Bilateral bronchiectasis is a possibility. Lower zone predominant bronchiectasis. So in a recurrent infection, I'll also look for any signs of any sequestration also, but I'm not seeing any signs of consolidation or collapse. So I'll arrange for an HRCT of the lungs to see whether to characterize that bronchiectasis. So
so this X-ray is from 2 months later when she had another episode of chest infection.
So here I can see tubular shadows and cystic round shadows in the right lower zone and right paracardiac region with probably bronchial wall thickening and bronchial cuffing and consolidations. So I'm again thinking the possibility of bronchiectasis and cystic and tubular bronchiectasis, and also associated infection. So I'll arrange for a CT to see further evaluation. So these are the serial axial sections of CT. I can see a lobulated cystic lesion with thin walls involving the right lower lobe, superior segment and medial segment of right lower lobe with some septations, and I'm looking for any continuity with the bronchus. So it can be varicose or cystic bronchiectasis is a possibility, but I will always look at the coronal images and to see whether it is continuous with the bronchi. Yeah, in the it looks like cystic bronchiectasis. Cystic bronchiectasis involving the segment, but since it is from childhood, it can be a sequestration is also a possibility. I look at the sequestration with the repeated infection is a possibility. I look at the mediastinal window to see whether there are any blood vessels coming from the systemic supply. I am looking at the aorta. I'm looking at the descending thoracic aorta, and I can see some branch that is coming from below from the celiac artery, and that is coming up, and that is supplying the lesion. So it is a extra pulmonary sequestration with recurrent infection causing cystic changes. So this explains the patient's recurrent infection. So I'll discuss with the referring clinician and will arrange a referral to a cardiothoracic team and discuss it in the next pulmonary meeting. I can also see some anterior mediastinal residual anterior mediastinal mass after the surgery here in this patient.
That's been stable, and it was chemo for lymphoma.
Okay. Okay, then if it is, I will compare the previous images, and if it is stable, then I'll note down in my report and discuss with the clinician. So my time is up, Harish. Okay.
Yeah. Okay, so that one was good. It's essentially like two cases, right? There is no connection between lymphoma and sequestration. It's just that the first X-ray actually did show the right lower zone cystic change as well, but it's much less important. I don't think you'll be penalized for that. The more important thing was the tumor there. But yeah, good diagnosis of sequestration. And yeah, always sequestration, the reason I showed this case is sequestration need not always be an area of consolidation or a solid opacity. It can be multicystic, and occasionally it can even be a single thin wall cyst. In that location, in the bilateral lower zones, and with that history, always look for an aberrant vessel. Or just say that you'll look for an aberrant vessel. And if they then give you a mediastinal window series, then that means they may be trying to show you that. The one before was organizing pneumonia. Nice call of the et al. Sign or reverse halo. It's not specific. It was described in the beginning in organizing pneumonia, but we know that lots of conditions can give it. So your differentials were good. Again,
and can we tell like if it is presenting now, I will think the possibility of COVID-19 like that?
I don't think the et al. Appearance itself is that, but there is a organizing pneumonia syndrome which you're getting secondary to COVID. So yes, I think it's completely reasonable. In the acute phase, it's mainly this peripheral ground glass opacities, and then the solid and then the rounded ground glass opacities. The central clearing is not that well described in that acute phase of COVID, but lots of people are getting organizing pneumonia secondary to COVID. And the other thing with organizing pneumonia is we like to call it COP, but not every organizing pneumonia is cryptogenic. It's better to say organizing pneumonia because lots of them can be secondary to other infections triggered by other infections, drugs, collagen vascular diseases, and if everything is excluded, then it becomes cryptogenic. And how you confirm is, as you said, trial of steroids if your level of suspicion is very high. But if you have some nagging suspicion that this may still be some kind of infection, you do a bronch and wash to exclude infection first and then give steroids, just to make sure it's not some atypical infection which may get worse if you give steroids. But in that case, yeah, you would treat it as organizing pneumonia. And the case before was fibrosing mediastinitis. That's a good call. Let me just bring it up.
Yeah, I got it only finally last.
I think those MIPs are actually quite helpful. The lung parenchymal changes are not severe enough to cause that severe pulmonary arterial hypertension. So in this case, pulmonary arterial hypertension is mainly from all of these multifocal stenosis of see that vessel is stenosed, and then there is post-stenotic dilatation. There is some stenosis here. This one, there is significant post-stenotic dilatation here and stenosis. And it's not just the pulmonary arteries, the pulmonary veins are also, see this pulmonary vein is just abruptly stopping there. This one's a bit irregular. This one's also abruptly stopping there. And the airways as well. So the airways are definitely getting stenosed as well. So yes, it does look like silicosis or even sarcoidosis can give you the same appearance, but eventually it's caused granulomatous fibrosing mediastinitis, which is what is actually causing most of those pulmonary hypertension changes.
So we'll suggest EPUS guided biopsy then?
Yes. So
okay.
There are two things, right? The diagnosis of fibrosing mediastinitis is an imaging diagnosis. You can't really prove it on histology. But what is causing the fibrosing mediastinitis? In this case, it looks like granulomatous fibrosing mediastinitis, which you get from TB. This doesn't really look like TB. You called it tree in bud. I don't think it's tree in bud. It's more perilymphatic. It's all pleural based. So granulomatous fibrosing mediastinitis you get in TB, silicosis, sarcoidosis. You can get fibrosing mediastinitis from other causes as well. It can be idiopathy, it can be secondary to radiation. But when you've got such lung changes and nodes, then you're thinking of granulomatous fibrosing mediastinitis. So the EBUS is to look to confirm the cause of the fibrosis, not to diagnose the fibrosis itself.
Okay, right. That was a tough case. Thank you.
Yeah, no, you did well. Okay, shall we move on?
Yeah. The next one is Dr. Sabahat. Are you ready, Sabahat?
Yes. Hi, Dr. Harish.
Hi, Sabahat. Okay, give me one sec.
So I'm keeping the timer on. Okay.
Okay. So it's a
Thank you.
70-year-old with cough for 2 weeks.
Okay, so this is the frontal chest X-ray of a 70-year-old patient with cough for 2 weeks. Now I can see that there are tubular changes in the upper zones of both lungs with adjacent fibrotic changes in the parenchyma. The hilar also appears to be a bit retracted upwards. The lower zones of the lung also demonstrate a subtle interstitial thickening. The diaphragmatic contour is outlined well. The hard border is a bit shaggy, but I do not see any retrocardiac opacity. I'm looking at the rib cage and the scapula to look for any osseous destructive lesion, which I haven't been able to pick. So in summary, this is an old patient with a cough having mainly upper zone changes with tubular appearance and fibrosis and retraction of hilar. I'm thinking this could be number one, a reactivation of prior TB, tubular bronchiectatic changes which have been now with the superimposed infection. I would, of course, compare it with the previous chest X-ray, whether this is any changes of radiation pneumonitis, and proceed with chest CT. Okay.
So this X-ray is from 6 years back.
Okay, so this is chest X-ray of the same patient 6 years back, which shows a nodule in the left upper zone. It is a bit speculated and irregular, and I would inquire the clinician if 6 years back this turned out to be a neoplastic lesion. In that case, a lung cancer would explain that this patient had radiation. After the resection, there could have been radiation.
There is no history of cancer.
There is no history of cancer. Okay. So after neoplastic, I would keep it as infective, considering whether this is a tuberculous infection and the rest is the post-sequelae, which we are seeing now.
We also found this X-ray from 7 years back in the film back.
Okay, so this 7 years back is tubular bronchiectatic changes, dilated bronchi with finger and glove appearance. So now I'm thinking towards the cystic fibrosis. And in that case, his medical history would give us a very clear clue that this patient had cystic fibrosis and recurrent infection, which would explain his present scenario as well. And a chest CT would add to the evaluation if needed.
So, patient didn't have any childhood symptoms or infections and no family history or no history of cystic fibrosis.
If this is not cystic fibrosis, if this is not neoplastic, the other thing which I can think of that at times a central endobronchial carcinoid tumor, which is slow growing, can lead to bronchiectatic changes and filling in with mucus and plaque. And secondary infection, that can be another explanation for this chest X-ray findings.
We also found this CT from 7 years back. The only positive history for the patient is chronic asthma, no other history.
Chronic asthma. So this is chronic asthma, and these are mucus-filled bronchi. So in the context of asthma, this is allergic bronchopulmonary aspergillosis, hence recurrent infection in this patient. This patient would need referral to pulmonology for management.
This is a 73-year-old with low-grade shortness of breath for months.
Okay, so a frontal chest X-ray of a 73-year-old male with shortness of breath. And I believe I heard low-grade fever, if I'm not...
no fever, just low-grade shortness of breath over months.
Okay, shortness of breath over months. So what I can see is that there is an opacity involving the lower zone of the left lung field. The diaphragm is elevated. I can also see cavity or an air lucency within this opacity of the left lung. The mediastinum is also shifted to the left. I'm looking at the rest of the lung parenchyma for any additional nodules and the osseous skeleton for any destructive lesion. In summary, this is left lower lung zone opacity with air lucency and shifting of the mediastinum. In this age, I would strongly suspect central hilar lesion, neoplastic, with cavitation, which is leading to this elevation of the diaphragm and collapse of the lung. I would immediately convey the finding to the clinician and arrange a contrast enhanced CT chest. And of course, I will look at the previous chest X-ray as well. And the patient should be discussed in the respiratory MDM after the CT.
We couldn't find any old imaging. We did do a lateral though.
Okay. So in the lateral, I can see the right and the left diaphragm. And the elevation is obvious. I can also see that there is air lucency within this soft tissue density of the left lung. I should also keep, although I would keep neoplastic as my prime differential, I would also look at the labs and think about an abscess. But still, I would
It's
keep—
got no acute symptoms.
No acute symptoms. I would keep neoplastic as my prime differential. What else it can be? I do not see any. The other possibility could be that there is a defect in the diaphragm, and this could be a diaphragmatic hernia with a herniation of the stomach into the thorax. That can be the other differential. A contrast enhanced CT chest would help. Okay, so these are sagittal images of contrast enhanced and oral in contrast CT chest, which clearly demonstrates a defect in the diaphragm and herniation of actually the large bowel into the hemithorax. The stomach itself with its orophyll contrast still seen beneath the diaphragm. So I think this is the diaphragmatic hernia, and the patient needs to be referred to the surgery, the thoracic surgery for surgical management in this patient.
This is a 44-year-old with acute chest pain.
Okay, so this is a frontal chest radiograph of a 44-year-old with acute shortness of breath.
Acute chest pain.
Acute chest pain. What I can see is that there is a clear area of lucency on the periphery of the left lung, where I can, which is denoting pneumothorax. I can also see that in the lung parenchyma there is diffuse tiny nodules throughout. I would be this is a female patient. I would be comparing it with the previous, and I would be concerned whether this patient has cystic lung disease. And in this female, I would consider lymphangioliomyomatosis, which can lead to chylothorax and this pneumothorax in such patients. The patient can, I would discuss it with the clinician and the pulmonology, and would arrange a CT chest for further evaluation if not done before. Okay, so this is the HRCT, which demonstrates chest tube in situ, and it is filled with cysts of varying, very well-defined cysts of almost same size and shapes. The previously noted pneumothorax is almost resolved. The patient being a female, and with this picture, I would keep lymphangiomyomatosis as my prime differential. LCH being less likely because I do not see any granules. And lymphocytic interstitial pneumonia would also have a different pattern. This patient would be referred to pulmonology for management.
So this patient's acutely unwell and febrile.
Okay, so this is the frontal chest
34-year-old.
Chest radiograph for 24-year-old who is febrile, acutely unwell. And with the presence of leads, I know that this patient is most likely in ICU recess. So this, I can see diffuse nodules in both the lungs and actually consolidative changes as well, with cavitations in many of them. There is no zonal predilection. I do not see any pneumothorax. I can see a right-sided central line, which means this is being used either for antibiotics or chemotherapy. But this patient is 24-year-old, acute symptoms. I would inquire about any history of drug use as well in this young patient. Considering the
IV drug user.
Yes, considering this history of drug use and acute symptoms and these dispersed cavitating masses in both lungs, I would keep septic emboli as my prime differential. And I would advise an echocardiogram as well to rule out any septic focus in the heart, and an HRCT would also help. So these are lung windows, CT chest, demonstrating endotracheal tube in situ and scattered diffuse cavitating nodules in both lungs. And I would still keep septic emboli as my prime differential in this patient.
Okay, so patient had an echo and showed some vegetations and was treated for infective endocarditis. Was improving, but then collapsed on the ward with acute severe hemoptysis and hypertension. And this is the CT after that.
So he collapsed with acute severe hemoptysis and hypotension, which means this patient is losing blood, and we need to find the source of his blood loss. So I'm looking at the vasculature. I think we should be looking at the bronchial arteries, perhaps. The pulmonary trunk itself looks okay. Okay. He has hemoptysis. So there must be some, okay, I think in the right lung lower zone, there is contrast opacification, which means that he is, this is the area of bleeding, and hence he has this hemoptysis. This patient needs a referral to the interventional chest radiologist and involve the thoracic surgeon as well. And we would try to do embolization for this bleeding artery and hence manage the patient.
Why do you think he's causing the bleeding?
Because of the infective endocarditis and the sepsis, the vessels are now friable and hence prone to those pseudo aneurysms, sacral aneurysms, which can ultimately bleed and cause hemoglobin drop in these patients, I think.
Do you see any aneurysms here?
I think at the point in the right lung lower zone, the contrast opacification seems to be, this vessel becomes a bit rounded, maybe here?
Yeah,
exactly.
Time is up, Harish.
Okay, sorry.
Okay, very good. So yeah, let's just look at this one. Yeah, very good. I'll X-ray for CT, very good. And this is also a really good finding. It's really rare, but yeah, you could get myocardic aneurysms anywhere. In this case, there are actually multiple myocardic aneurysms. So I don't know if my arrows are, one second. I don't know if my arrows are visible,
we can see
but
the arrow.
one
we
there.
can see your cursor. Oh,
yeah.
arrow. Okay,
so there's
yeah.
one there, one there, and
yes.
there is another one here.
Yes.
And there is one here, which is probably the one which is bled. So this was multiple pulmonary artery myocardic aneurysms in the setting of infective endocarditis and septic emboli. He didn't survive the bleed.
First time for me to see such a case. Excellent case.
Yeah, it's really rare. But yeah, you're right. You will generally look for bronchial arteries in the setting of any hemoptysis, but less commonly, you could get bleeding from pulmonary artery source as well. So common causes of pulmonary artery source hemoptysis would be you could have a pulmonary AVM. They are always
Yes.
pulmonary artery to pulmonary vein, not bronchial. So it's important in determining what technique you would like to use. Would you scan at the systemic arterial phase or do a CTPA? The
True.
other is in cavities. You could get Rasmussen's aneurysms, which are also pulmonary artery origin.
Yes.
And then rare things like this. Okay, very good with LAM. The only thing which I would have given you a 6 for that, except ideally if you had said you would look at the kidneys, look for angiomyolicomas, because
Yes.
40% of LAMs are in the
Yes.
setting of tuberous sclerosis, and also they could also get bone lesions. So this may not be that, but if you say I'll look at it, you get full credit for it, regardless
True.
of whether they have it or not. The diaphragm was good. I think calling the whole thing a tumor on the chest X-ray is probably not the most likely situation. On the lateral, I think, let me just bring that up. On the lateral, I think you could see some hostile markings, but you actually did say diaphragmatic hernia in the lateral, so that was good.
Right.
It need not always be a hernia, especially in a relatively older patient like this. So there are some hostile markings here.
Yes, there are.
That one,
Now I
that
can
one.
see it. Yeah.
And on the CT, it was very central, right? It doesn't really fit with a Morgagni hernia or a Bogdalic hernia. And so
Yeah.
the other cause for a very similar herniation would be a traumatic diaphragmatic rupture. You would often think of it as a very acute thing. It is often not. In fact, most of the patients with non-major diaphragmatic rupture would present quite delayed, because at the time the defect would be quite small, but then over time, when the intra-abdominal pressure increases, it starts to herniate, and then the defect grows. So it's not uncommon for people with trauma from 20 years back presenting now with, once their herniation is big enough to start causing pressure effects. So this was actually a traumatic rupture rather than a hernia, but you can't really tell them apart. It's just the location. And the first one, ABPA, that was ABPA. Yes, cystic fibrosis, yes, definitely yes. After that, ABPA is what you always think of when you see bronchoseals, finger and
Right.
glove.
Yeah.
Your possibility of any endobronchial obstructive lesion causing distal bronchoseals is very valid, except it shouldn't really be bilateral multifocal. It should be one or two
Unilateral,
bronchoseals
yes.
rather than everywhere in the lung.
Yes.
Okay.
Harish, we have half an hour left. Can we examine two more?
Yeah, I'm happy
candidates?
to. Yeah.
Yeah, thank you very much. Are you available, Ijaz?
Dr. Ijaz?
Hello. Yeah, I'm there.
Okay.
Excellent. Sorry, I didn't get your name. Ijaz?
Hello. Yeah, Ijaz.
Ijaz. Yeah. Hi, Ijaz. Okay.
Yeah, I'm keeping the timer.
Okay. So your first case, Ijaz. No history provided. It's a warm-up case.
I have been provided with a frontal radiograph of a skeletally mature individual. I can see that there is a pacemaker with cardiac leads seen, and with the tip of the leads in the right atrial region and in the left ventricle. And I'm seeing a nasogastric tube, which appears to be extending into the right bronchial right bronchus, and with the tip lying in the lung.
Okay, reposition. Okay, next case. This is a 79-year-old with fever and chest pain.
I have been provided with frontal radiograph of a skeletally mature individual, 79 years old with fever. At the outset, I can see that there is a near circumscribed opacity seen in the right mid zone with the air fluid level, with and adjacent mild airspace of opacification. So considering the I'm seeing rest of the lung fields, mild bronchovascular marking seen. Okay, the lateral, on the lateral I can see that uh, the opacity is mm, the opacity is seen in the middle mediastinum overlapping the cardiac shadow. So this could be uh, lung abscess with an adjacent consolidation change. So I would correlate my findings with any previous X-ray available, and to know whether it's a new lesion or it's a pre-existing pathology, and refer the patient to uh, pulmonologist for further evaluation, and also do a follow-up X-ray after probably a course of antibiotics.
Would you do a CT?
Yeah, and I would refer the patient for CT thorax for further evaluation. Yes.
You would generally not do a CT for infections, but once you start to see an
Yeah,
abscess,
lung
then you would do
abscess.
a CT.
Yes, yes.
Yeah.
I have been provided with.
24-year-old.
Okay, sorry.
Low-grade chest pain for weeks.
Okay, I have been provided with frontal radiograph of a skeleton wedge individual, 24 years old patient with low-grade chest pain. At the outset, I can see that there is a large near homogeneous opacity seen in the right upper zone, upper thorax, which is extending from the superior aspect of the mediastinal contour and extending upwards till the in the lower cervical region. The lateral border of the opacity is well defined. The middle border could not be visualized and appears to merge with the soft tissue shadow. So, considering the cervicothoracic sign is present, so in that I would think the mediastinal lesion, this would be a superior mediastinal mass which is extending into the uh, lower cervical region. There is no extension till the level of thyroid. So my differentials would be uh, sorry, posterior mediastinal mass. That's what I meant. My differential will be that of a posterior mediastinal mass. The lesions could be either neurogenic or any duplication cyst or any infective etiology, and I would correlate in the lateral X-ray. On the lateral film, the opacity is seen to lie in the posterior mediastinum, overlapping and superiorly overlapping the vertebral shadows. So I would see for any previous imaging to rule out any chronic pathology, and advised CT thorax for further evaluation, and contrast study preferably, and refer the patient to respiratory, or refer the patient to pulmonologist for further evaluation.
So this patient's got chronic shortness of breath for a few months now. We don't have any X-rays. We just straight jump into the
Okay.
CT.
I have been provided with cross-sectional CT scan in the lung window of a skeletal mature patient. So I can see that there are multifocal geographical patchy densities seen diffusely scattered in the lung fields, uh, more predominant in the perihilar region, and there's no obvious gradient in the axials to the extent seen. So uh, I'd also look for in the mediastinal window for the nodes. So
Or no
considering the
nodes.
lung window, I would think in terms of a chronic infective pathology, and the mosaic attenuation uh, would think in terms of a chronic uh, hypersensitivity pneumonia or a chronic esophilic pneumonia. I would correlate with clinical findings and any previous imaging available to look for the chronicity of the disease, and look for the blood parameters to look for any eosinophilia, and would also ask for the history of any allergen or any chronic respiratory chronic recurrent respiratory disease.
Okay,
For further
eosinophil count was normal, and there is no history of any exposure to allergens. And here is the expiratory series from the same study.
Okay. So there's no significant variation in the expiratory scan. So I would also rule out possibility of any uh, microemboli or like thromboembolism causing patchy changes. Uh,
Okay, so the scan also showed many nodules like this. So there were multiple such nodules, solid nodules like this. They're everywhere. One of them were subjected to a VATS wedge resection, and the histology came back as carcinoid.
Just a second.
Can you take the case any further with that new information?
So I would think in terms of a bronchoalveolar carcinoma, and I would correlate with previous imaging and further, and anyhow biopsy is done. So
it didn't show adenocarcinoma or in situ. It showed carcinoid.
Carcinoma. Okay.
Nothing more? Okay, we'll move on. Next case. This is a 29-year-old with cough and shortness of breath for 2 weeks.
So I've been provided with frontal radiograph of a 29-year-old with shortness of breath and cough. At the outset, I can see that there are large reticular densities seen in the right and left lung field, extending from the hilar region and downwards. There is relatively more severe, near homogeneous opacity seen in the left lower zone, and also I'm able to see a reticular lucency with peripheral peripheral density, which would suggest a uh, which is in a tubular configuration, likely which suggests a possibility of bronchiectasis. So and I'm looking for the any in my review areas for any lesions in the retro diaphragmatic or apical region. I'm not able to see any lesions. The rest of the bones appear normal, visualized bones appear normal. So considering these findings, I would think in terms of a chronic infective pathology with likely fibrosis and fibrobronchiectasis seen in the left lower zone. So I would communicate my findings to the referring physician and compare with any previous imaging available, and refer the patient for CT thorax for further evaluation.
So previous X-ray from 1 month back was normal.
Okay, so so this tells us that it is relative recent pathology, and considering the organizing consolidation change and bronchiectatic change, I would think in terms of COVID pneumonia in the recent pandemic, or any other infective etiology causing second with fibrosis like tuberculosis.
Harish, time is up.
Okay. All right. Let's just quickly go through this one. So I wouldn't really describe There are some reticular changes here, yes, but it's predominantly airspace, right? See how ill-defined these are.
Okay.
Yes, it does have some features which make you think maybe it's quite fibrotic, but if it wasn't there 1 month back, it's mostly more
Parenchymal, yeah.
active airspace changes. So on the X-ray, I mean, you can only give a list of differentials, right? But infection is good. Yeah, it's very symmetric, which is a bit unusual.
Yeah.
But this could well be infection. You would also think of non-infective things, especially when it's got this very peripheral pattern. Peripheral and airspace, there are a few things you would start to think of. And on a couple of cases, you said chronic infective pathology. That's really, so if you're thinking of old TB, then that's not chronic infection, right? That's a old infection with some residual changes.
Okay. Yeah. Okay.
Chronic infections would be
It's long term.
Yeah, there aren't too many chronic, and then you could get reactivation rather than only certain things would stay active and be
Is there a
chronically
bronchiectasis? No, like the tubular thing which is retrocardiac on the left side. Yeah.
there
this
is
one.
some suggestion, right?
Yeah.
I don't think there was.
Okay.
It may well be
That was
the
misleading.
degree of,
Yeah.
yeah, I think it's the degree of airspace change around which makes the bronchi stand out a bit more.
Okay.
But the CT will tell us. Let's look at the CT.
Okay.
So let's see if you can come up with anything on the CT.
Yeah.
So
Peripheral
you
fluid
were,
bands.
yeah. So there's no real bronchiectasis there. I think it was mostly the surrounding changes making it look like that. So
So this was like COVID.
No, this wasn't. This is 2000. This is from 2020, but the previous. So I'll show you the previous CT.
Okay.
That was from some time back. So this was the CT from the time of the.
So could be a chronic eosinophilic pneumonia, something like that.
Yeah.
A chronic
So,
hypertension.
COVID, yes, there is definitely a peripheral ground glass pattern described in COVID. But if we didn't, if we had seen this X-ray, the CT last year, 2019, I think chronic eosinophilic pneumonia would definitely have made it to the top of our differentials. It's reverse pattering peripheral airspace changes with some degree of fibrosis already starting to occur.
In the exam, you can just give a tell that this is a organizing consolidation change with and then tell differentials. That would
Yeah,
be
so
good.
that will be a more of a pathological description, right? So yeah, it's completely fair, but then your differentials would be true entities such as eosinophilic pneumonia, organizing pneumonia, which can be cryptogenic or otherwise, and infections, including COVID-19.
Okay.
All right. The one before so the quick X-rays, they were all good. There was nothing to add. The case before, I'll just bring it up again.
Mosaic attenuation. Yeah.
It's a very rare entity, and it'll be a gold medal case in your exam if you get this case, then you're probably doing really well. So the fact that it was a carcinoid, can you see those multiple nodules?
Yes.
So it's a combination of so with hypersensitivity pneumonitis, which is something you would definitely think of with that mosaic attenuation and ground glass change, but you don't get these nodules in HP. You get your centrilobular, very soft nodules. These are very solid nodules and not really centrilobular either. So when you have this combination of multiple solid nodules and ground glass change with mosaic attenuation, often with gas trapping, so just the fact that it looks like this, there is a bit of mass effect there, right? See how it's pushing all the vessels. So there is some gas trapping there. So does that combination ring any bells? There is this condition called DIPNEC, which is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Look it up.
No, okay.
It's something you always see in the case of the day in conferences. It's epidemic in conferences.
Okay.
But this was actually a proven case of Dipney.
Okay.
All of those lesions, we did wedges of multiple those nodules. They were all typical carcinoids. So it's essentially you have many carcinoids, but you also have diffuse neuroendocrine cell hyperplasia, and they grow in the vessels and also in the airways.
Okay.
And that's what gives you this mosaic attenuation and gas trapping, because
Okay.
once the airways start to get involved,
So the airways will be more of peripheral airways rather than we cannot make out on
exactly. You can't really see. So it's this combination of mosaic attenuation and ground glass change plus solid nodules, which makes you think of a very
yeah,
rare
it's very
entity.
strange.
I couldn't not show it, Ijaz.
Yeah,
I apologize.
no, that's okay. In the exam, if we get such cases, we can just tell differentials and
exactly. Yes.
I think it'll more of a discussion case.
Chronic, HP would be a very good differential here, and infection. It's just that neither of them actually.
That's what I was like, not very, because of finding there was no central lobular nodules, so I was just searching for them.
Yeah. I don't blame you at all. It's
no. Thank you for showing this case. Actually,
no worries. Got 10 more minutes, Anish. Should we stop, or I'm happy to do one more?
Actually, there is one more candidate. We can explain for 10 minutes only, maybe.
Yeah, sure.
Yeah. Dr. Manu? Hello, Dr. Manu?
Hello?
Yeah.
Am I audible?
10 minutes only. Okay.
Okay, Manu, let's go. This is a 49-year-old with chronic shortness of breath.
This is a frontal radiograph of a 14-year-old female with a chronic shortness of breath. The radiograph shows multiple tiny nodules and bilateral lung fields. The lower zone of bilateral lungs show have thin lung markings. The cardiomediastinal margins appear normal. The bony, the osseous structures appear normal. So in this radiograph, I'm not able to appreciate the lung markings along the bilateral lower lung fields, but this is pretty unusual for a pneumothorax. I press. I'm not able to locate any of the findings on this radiograph at present.
So what do you think are causing these lucencies at the bases? You can see some lung markings, and patient doesn't have any acute symptoms of pneumothorax.
This is almost bilaterally symmetrical and in the lower zones.
Non-smoker.
So this could be a bilateral giant emphysematous bulla.
But they are non-smoker.
Also, another pathology could be a high alpha-1 antitrypsin deficiency, which is more prevalent in females. So this is bilateral emphysematous changes due to alpha-1 antitrypsin deficiency.
This is a 44-year-old with shortness of breath for 6 months now.
Frontal radiograph of a 40-year-old patient with shortness of breath for 6 months. And this radiograph, I'm able to appreciate multiple reticulonodal opacities involving bilateral lung fields. There are contract and ring-like opacities in bilateral lungs, predominantly involving the right upper zone. The cardiomediastinal contour appears to be normal cardiogenic angle, as well as the osseous structures and the soft tissues appear normal. So this is a case of this could be a case of interstitial lung disease or interstitial lung disease with multiple lesions within, or it could be a case of bilateral upper lobe fibrosis. So I would communicate the findings to the referring clinician and the subject and ask for previous radiograms to know if it has been a long-standing finding. If it is not, then I will subject the patient to ultrasound and CT for further characterization. So I am provided with CT sections of thorax in the lung window, which shows ground glass opacities involving bilateral lungs with subpleural sparing. So my differential diagnosis in this case would be a non-specific interstitial pneumonitis. I would ask for a previous history of any rheumatological disease. There is no definite Israeli dietitian in this particular patient at present. Case will be discussed in the pulmonary team meeting for further management.
This is an 85-year-old with long-standing shortness of breath.
Frontal data of an 85-year-old patient with long-standing shortness of breath shows diffuse pulmonary changes involving bilateral lung fills. There are reticular opacities involving bilateral lungs, which are more predominant towards the upper zones and towards the periphery of the left lung. There is volume loss of the left hemithorax. There is no evidence of pleural effusion, as well as the osseous structures appears to be normal to the extent visualized. So this patient could be suffering from again.
Sorry, Mani, you are breaking up. I can't hear anything.
Okay, maybe there is some technical issues. And it's around 11 p.m. now. Thank you very much for keeping till this 11 p.m. Harish. And what I could say is it's just like real exam. The seat is very hot, and I can feel that heat, and it was really good. And all the cases were just like real exams. And what about Sabahat? What do you say?
Yes, of course, Dr. Harish. Thank you so much for giving us this time and a very excellent session. Enjoyed every case, and there were teaching points in every case. If it is possible for you, maybe you can give the feedback for the cases which Dr. Manu attempted. It would be helpful.
Yeah, we could look at, I'll quickly show the CT for this one. This is also a relatively rarer entity. It's a fibrotic lung disease, but it's not your UIP or NSIP or chronic HP. It's got a peculiar pattern of very upper zone predominant fibrosis with pleural thickening as well, quite significant pleural thickening here. So there is lower zone fibrosis as well, but it's relatively upper zone predominantly. So this is this entity called PPFE, pleuropulmonary fibroelastosis. Again, it's not something you would be expected to say. If you can give a relatively good differential for predominantly upper zone fibrosis, I think you will pass. But PPFE is one of those idiopathic fibrosing lung diseases which predominantly affects the upper zone and almost always has these significant pleural changes. One thing you would always consider when it's upper zone would be chronic sarcoidosis or silicosis, but the main differentiating feature is fibrosis in silicosis, which is PMF, is generally more central. The fibrotic lung generally tends to gravitate towards the hila, leaving behind this emphysematous lung in the periphery. This one's just the opposite, right? All the fibrosis is very peripheral and in touch with the pleura rather than central. So that's why this is less likely to be chronic silicosis or sarcoid. But other things like angst-pond, previous infection, radiation, all those things can give you a similar appearance. But this is one other condition. What else did we look at? NSIP was good. There was subpleural sparing, and always ask for collagen vascular diseases in the history, and also you'll do a full immunological panel, because idiopathic NSIP is really not a thing. Even if you can't find anything, it's just that the collagen vascular disease hasn't started yet. NSIP is virtually always secondary to something, not just collagen vascular diseases, but drugs or other things. But idiopathic NSIP, it's debatable whether it's even an entity. And the first X-ray was alpha-1 antitrypsin deficiency. That was it.
Yeah, Harish, we really enjoyed the session, and we are very thankful for your kind gesture. And thank you very much. Have a good night.
No problems. Thanks everyone for coming.
Thank you very much, Dr.
Bye-bye.
Harish. Really appreciate it. Bye-bye. Thank you.
Good night.